I'm going to talk about general ethical kind of reflections on the issue of substitute decision-making, and just try to give you the summary of what might be a whole lecture or two if we were doing this in detail. So, my goals, again, as a teacher, are threefold. First, I want to situate for you substitute decision-making in healthcare ethics. When we say substitute decision-making, how does it fit? In what context does it fit in terms of ethical approaches to decision-making? Second, I want to really clarify the particular issue of the goals of advanced care planning and the role of substitute decision-makers. We'll see that advanced care planning has a very important role in healthcare ethics. And then substitute decision-makers really ought to be bound by much of the reflection that happens in advanced care planning. So generally in ethics, advanced care planning, and then to identify some challenges for ethical decision-making, even with advanced care planning and prepared substitute decision-makers, even with. So you see, if you sneaked to the end of the slides, I have a picture of both the Bentley case, the woman in the Bentley case, and Mr. Razzouli in the Ontario case. Interestingly, both of those very contentious issues, one had an explicit instructional directive and adult children who wanted it followed, and it was a mess. The other, Mrs. Razzouli, is actually a physician, very well prepared to act as the substitute decision-making for her husband. And yet, even with some of what we're going to now put forward as important, problems happen. Decision-making in these delicate areas is going to be complicated. So let's situate this in modern bioethics. Most everyone in this room, regardless of where you come from, knows the dominant approach to ethics. It is not the only one. It's the dominant approach in North America since the mid-60s. I can give a whole lecture on why it happened. Essentially, it's called the principle-based approach. It's an approach that says, when we're in a pluralist society, so you may have a Muslim patient, a Roman Catholic doctor, an Orthodox Jewish nurse, and the questions about the right and the good will cross all of those because the hospital administrator is an atheist. And the question then becomes, with increasingly difficult decisions, increasing power of medicine but increasing risk, can we have some kind of agreed principles, at least first principles, for having a conversation across cultural and religious lines? And the principles then became respect for autonomy, beneficence. Beneficence belongs to the Hippocratic tradition, do good, bene, do good. Non-maleficence, Hippocratic tradition, do no harm, meaning do no more intentional harm than medically measured good. And justice, non-discrimination in care. Note the new principle emerging in the 60s and 70s in contemporary Western society is respect for autonomy. Now, respect for autonomy is the principle that recognizes that it's the person, client, patient, because you use the language differently, I'll use patient, it's the person's right to make health choices consistent with their values. But this becomes important. I list respect for autonomy, beneficence, non-maleficence, and justice as if they were in order. They're not. I could scramble them and put justice first. Morally, they are of equal weight. In contemporary Western society, autonomy dominates, and misunderstandings of what autonomy is about. I am not a Walmart clerk. So a patient may have wishes about a certain intervention. My obligation as an allopathically trained doctor is to make sure I balance scientifically the benefits and harms. So when a doctor comes to a patient to offer a range, it is a narrow range of options. And they have to have in some way some kind of standard of care. But it is the patient who then makes a choice, because in every serious issue there are options. This may mean a loss of your leg, but a better 5-year survival. This would keep your leg intact, but in fact, a 30% less chance of 5-year survival. It is the patient, it is the person who in fact makes choices, and those choices should be consistent with things that are important for them. Informed choice, so informed consent is the way most of you talk about it. Gerrit can talk about informed consent. Don't talk about informed consent. It presumes that the issue is you consent to what the doctor's giving you. The moral question is informed choice, which is morally you can either consent to or refuse. They're equal weight. You're the one consenting to or refusing. So informed choice is a tool to promote autonomy, which incorporates within it not just decisional autonomy. The informed respect for autonomy is about dignity and personhood. It isn't just about decisional competence. We'll come back to that again. So, bioethics principles, general now in Western pluralistic society. Respect for autonomy is an important one, but all of them are important. Informed choice is the tool, and informed choice has 3 requirements to be met. Information, capacity, or competence. Competence is what the law generally talks about. Capacity is generally what ethics talks about. And freedom or voluntariness. The elements are important because the issue isn't what I told you, but I gave him the information. The requirement for informed choice is met when the person has the information they need, not when I've told them what I wanted to tell them. It becomes very important in terms of understanding, again, respect for individual diversity, things we've already spoken to. Then the issue is, so the person's given information. Then we have the ethical requirement for capacity. This is what it means ethically, not by psychiatric terms or medically, legally. Capacity is the ability to understand the information given them, understand the options, and understand what that would mean for them. If in fact I go with the amputation, but I'm a dedicated runner, what does that mean to me? Do I have the capacity to incorporate? Because when people are giving a yes, when they're consenting to a procedure, I assure you they're not consenting to the risk. In real life terms, they're only consenting to the benefit. And when I told them there's a 30% chance of the risk, and the risk happens, they say, what did you do wrong? So capacity is the ability, information that they need, capacity, you understand what it means, and then freedom or voluntariness. We're moving now into something very important for third-party decisions. Nobody's totally free. They're surely not totally free to make a decision when you're sick. It's sufficient freedom, and the freedom that we're talking about ethically is from coercion, from undue fear, and from guilt. Now just think, we're not going to stop here because we're going to do it all, and Romayne actually may have examples of this. If your son is angry with you and guilting you into going back to the OR when you're perfectly prepared to die, you're not making an informed choice. And it's the freedom component. It's the freedom component. And we don't think of that. We're always thinking in terms of the informational component. So, elements of informed choice, which extends autonomy, information, capacity, and freedom. All I'm going to say here is the determination of capacity ethically or competence in psychiatric terms or legal, this is no easy thing. And we had this magnificent kind of reflection on dementia and its course and stuff. I learned tons of things. But the interesting thing is that this capacity and the capacity determination in the elderly in particular, it's fluctuating, it's varied, it's deteriorating, but it's irregular. And this becomes a very difficult part of informed choice and respecting persons. So, from the general ethics perspective, we would say respecting persons, which is the ethical obligation, is more than respecting decisional autonomy. Second, that truly informed choice is complex. We're not like little computers where the doctor goes in and tells you 10 things. I'll be back tomorrow morning at 8. You give me the answer, and then we process it and give an answer. The information, capacity, freedom, these are complicated issues. And then finally, the judgments regarding competence and capacity can be very difficult. Now, if it comes that you are no longer able to exercise autonomy, decisional autonomy, one of the tools that we have developed, one of the approaches, is substitute decision-making. Someone who will speak for you. But this becomes crucially important. These are the ethical requirements for substitute decision-making. Remember what it's supposed to be. Ideally, when you cannot speak for yourself and express your values in your choices, someone who knows you, knows your values, and will try to be your advocate not for what they want. I don't really care that your daughter isn't ready to let you go. If she's acting as your substitute decision maker, her ethical requirement is to act as best she can the way you want her to. So the ethical requirements for substitute decision makers, this becomes very interesting. People can be appointed and have legal authority as a substitute decision maker, and they don't fit the moral requirements. They don't fit the ethical requirements. This is when we get into the big trouble. So just briefly, what might they be? The patient must be incompetent, or the patient must have made the decision, and Romayne talked about this, to say, look, I've never made big decisions. I've always depended on my husband. He's gone now. My son Robert is going to be, and then they have passed over to the son. It still becomes an ethical obligation for the doctor because you want to make absolutely certain that the son is able to fulfill these requirements. But nevertheless, in general terms, just because you have a mouthy daughter who at least is intelligent and you can speak to her, does not mean you bypass the mother who is confused. In order for, and the more serious the decision, the more important this ethical requirement. The patient must be incompetent. A decision must be made. You don't have third parties deciding things that don't need to be decided. The substitute decision maker must fulfill the elements of informed choice, information, capacity, and freedom. So hold the phone. If you're a son and you've not spoken to your mother for the past 6 months, and now she's dying and you're called in from Toronto, if your guilt is overwhelming your ability to act for her best interest, you don't fulfill this requirement. Can you understand how, from the ethical perspective, this is complicated stuff? Now, for never competent persons, babies, children, the substitute decision maker is in fact using a best interest standard. Mommies and daddies are not proxies, they're surrogates, appointed and understood in law and by social practice. They and the doctors try to figure out what's in the best interest of this baby, because the baby didn't have a life that could express values that they give to the substitute decision maker. But for previously competent patients, the decision ought to be made as the patient would want using substituted judgment. So, the process then for advanced care planning, which would include the naming of a proxy, first an important step, clarifying values and hopes for care when you're not competent. Second, conversation with everybody you have to have the conversation with. Don't appoint your youngest son your proxy and fail to tell your firstborn daughter. Disaster guaranteed. And then you need to complete an advance directive. That's the third component. It's the values clarification and the communication that's more important. And the advance directive, historically people have talked about a living will. That's an instructional directive. If this happens to me, take one from column A, one from column B. Never works. Total disaster, and there's been much ethical literature. But appointment of a proxy believes that it's better because it works this way. If I appoint Romayne Gallagher, because she's a friend of mine, I say, Romayne, if I become incompetent, will you speak for me? I may give her general instructions. Nuala, let's go. I mean, I know your general values. We've talked about that before. Are there any specific? I may write a few things. But what I'm depending on is that Romayne, if it happens that I become incompetent, will try to get inside me and my value system and speak for me. What a tough call. What a tough call. We are underestimating this. So, I just want you to know that there are big, complicated difficulties when we think about substitute decision making. Even when you have done advanced care planning, even when you have clarified wishes and had conversation, and even when you appoint a proxy who does know what it means, Now, of course, if you don't appoint a proxy, that is when there will definitely be a disaster at the bedside, particularly if you have multiple family members or previous marriages and children from absolute nightmare, because in fact the law will then capitulate to some kind of an ordering, and the person who may be legally responsible does not know you at all. So finally, advanced care planning, thinking about proxies, appointing them, appointing substitute decision makers, is clearly a necessary phenomena in our world. But I've said to you, it doesn't mean that at the end of the day, in this situation, here and now, after the person has become incompetent, that you in fact can know exactly what to do. And this becomes important. We have to respect the person's wishes, but if in fact the person, as in the Bentley case, made clear statements about some things, but they seemed to violate every professional standard of what ordinary care was like. The Bentley case was, I don't know how, so upsetting. It was trying to make ordinary feeding by mouth a medical act. Now, interestingly, in the Rizzulli case, they were trying to say that the continuation of ventilator support was, in fact, ordinary care. Duh. Did you understand what I said? Two absolutely radically different approaches to what was being asked, and yet both of them were situations where they fulfilled some requirement for advanced care planning. So that's basically real fast, too fast, the ethical background. But as we hear now about cases, and Gerrit talks to us, and then we talk about cases, that's the background stuff that I think we have to keep in mind. Substitute decision-making, a great, great moral responsibility and gift you can give to your loved ones, but very, very, very tough.